Good morning. Today we talk about the disorders affecting facial nerve. A facial nerve is a bilateral nerve that is present on either side of the face. The nerve exits the brain through the stylomastoid foramen, which is just anterior to the mastoid process. It then enters the substance of the carotid gland, wherein it divides into its five terminal branches. And these five terminal branches are responsible for moving of the facial musculature. Now we come to the functions. So the main function of the facial nerve could be classified as maintaining the muscular tone. The muscular tone of that particular side of the face with the nerve or facial nerve palsy would be completely gone, and you can find that part of the face will droop down. The muscles, the skin, everything will droop down on that side affected by palsy of the facial nerve. It also helps in the facial muscular activity, the movement of the lips, the eyes, and cheeks, and all the skin moves with these muscles. And the muscles of facial expression. One end is attached to the bone, and the other part of the other end of the muscle is attached under the skin. So the movement or the contraction of those muscles of the facial expressions will bring about movement of the skin, thereby producing the facial expressions. The other is also the emotional expression, not only just your articulated expressions like moving our lips or causing a smile or twitching our facial skin. More than that, it also helps in the emotional expressions, like when you are deeply affected by sorrow, that the pain is found or seen in the face. And that also is mediated by the movement of the facial musculature, which is again mediated by the facial nerve. It also helps in the taste sensation, again mediated through the chorda tympani. So how would you assess the facial nerve? So compare the expression and movement between the two sides. When you sit the patient, you actually sit the patient in front of you and ask the patient to raise the eyebrows. And when they do that, if there is palsy on one side, that eyebrow will not move up, and you will be able to diagnose the fault. So things that we ask to raise the eyebrows, ask to tightly close the eyes, ask the patient to grin or smile, showing their teeth, and also test the taste. So the etiology of facial palsy. The facial palsy can be due to two reasons, that we say central or upper motor nuclear lesions, or peripheral, which is through the lower motor neuron lesions. So the upper motor neuron, which is present in the brain at a higher level. So these lesions produce contralateral lower facial paralysis. So if there is a right side upper motor neuron lesion, then the paralysis would involve the left side. That's the contralateral. Now the frontalis muscle, which is the muscle on the forehead, is spared because of the bilateral innervation. Now as the fibers of the facial nerve inside the brain, as it traverses from the upper motor neuron to the lower motor neuron, it actually decussates in the midline, and the fibers which supplies the frontalis actually is bilaterally innervated. Of the left side, as well as a few fibers from the right side, also joins together. So both the sides, the nerve fibers from both sides actually supplies the frontalis. So if a upper motor neuron lesion affects the facial nerve paralysis, will not the frontalis muscles will not be affected. Emotional response is preserved with the upper motor neuron lesion. That is again an important thing to remember when these patients have a facial palsy, but the emotions bringing about muscular movement will not be affected. The muscular movement will not be affected. The Bell's phenomenon, but is actually a lower motor neuron phenomenon that affects the LMN. Now, what are the tests that we prescribe for checking the facial nerve palsy? Schirmer's test is done for checking lacrimation, that is the greater superficial petrosal nerve is tested. Stapedial reflex test, taste testing, that is again the chorda tympani nerve is tested by testing the taste, and salivary flow rate. Now, how do you do all these? So, Schirmer test is you're actually placing a piece of blotting paper with measured markings inside the eyelid and checking whether the wetness of the blotting paper has happened, which with the normal patient as well as an affected side. So this normal side and the affected sides can be different. So that is reduction in the lacrimation. And stapedial reflex test also the audiometry, or you can see whether there is a hearing is affected. And taste testing again, dropping salty or different taste materials onto the tongue, and whether the patient can feel the taste or sensation of taste can be affected. Now, the trauma, etiology of facial palsy can be due to trauma and soft tissue lacerations, especially on the face. Fracture of the ascending ramus or the condylar neck can bring about injury to the main trunk of the facial nerve. Fracture of the petrous bone in the skull base can bring about, again, facial nerve palsy, because the nerve traverses the petrous bone as it exits the brain. Neuropraxia or delayed paralysis are usually the sign. And middle ear or mastoid surgery, again, the middle ear or the wall of the middle ear contains the passage of the facial nerve along the wall. The gunshot wounds also can be an etiology. Now, there is a specific disease called Ramsay Hunt syndrome, which is the pain in the ear followed by lower motor neuron paralysis. So these particular disease is brought about by varicella zoster virus. It starts as a vesiculation of the external ear, concha, palate, external auditory canal, and it brings about pain in the ear or otalgia. This otalgia is the beginning sign, and then it is followed by facial numbness. Moving on, the etiology of facial palsy can be congenital due to birth trauma. If you remember the olden days, they used to have for a normal vaginal birth, they used to have certain forceps kind of things which will engage the baby's the lower jaw. The forceps is attached to the lower jaw of the child, and a slight traction is given so that the baby can be removed through the birth canal. So that was an earlier. Nowadays, it is not being used anymore, but that particular forceps can press against the mastoid process and brings about the trauma to the facial nerve. Mobius syndrome is another congenital disease which affects bilaterally the facial nerve. Absolutely no movement of the face throughout that patient's life. Both sides facial nerve is paralyzed completely, and they have no emotional response. They have no eye movement, lip movement, nothing at all. It's also called a mask face syndrome. Another condition is called the jaw winking syndrome or Marcus-Gunn syndrome, which is again a rare condition, congenital or following trauma. It brings about ptosis, paradoxical oculopalpebral movement, that is the eye and the eye movement as well as the eyelid, provoked by chewing. When the patient chews, the movement of the eye and the eyelid is a movement that occurs during the chewing. Clonic facial spasms, again, one of the causes. Otitis media, that is miliary infection. In acute otitis media, dehiscence of the fallopian canal causes bacterial invasion. So by the bacterial invasion, you can get. So again, like I said, the facial nerve is lying very close to the middle ear wall. So any infection can affect the nerve by the compression or the pressure that is caused by the inflammation. Tumors, paralysis with parotid swelling should be investigated for tumors. Okay. Now, Bell's palsy is the most common lower motor neuron lesion. It is thought to be due to herpes simplex virus or even varicella zoster virus. And due to the facial nerve passage through a long and narrow bony canal, compression and ischemia occurs, and that causes the palsy of the nerve. So like I said earlier, the facial canal or the canal along the middle ear where the facial nerve passes is a very constricted area because it is bounded by bony walls. And when there is an inflammation due to a virus infection like varicella zoster or any other reason, any infection causes inflammation, and that causes swelling, and that swelling of the nerve, because of the constricted nature of the canal, this swelling will apply pressure on the nerve, thereby stopping the function. So classically, the clinical features are sudden onset, facial weakness, unilateral, which is preventing the wrinkling of the forehead and closure of the eyelid. So it's usually unilateral. And what happens is there is a forehead and eye closure is affected. Now, I said it's a low motor neuron lesion, so the forehead muscles are affected and eye closure is affected. That is what most of the patient complains about. The traction of the lip to one side on smiling. So the normal side will move and the affected side will not move. So there is a disparity between the lip line as the smile, as the patient tries to smile. Also, accumulation of food in the buccal surface. So in the area on the side where the nerve is affected, the movement of the muscles, which actually pushes all the food into the oral cavity, as because it's not happening, there will be food collected in the buccal surface. Disturbance of taste, obviously due to the chorda tympani nerve being affected, and it may also cause hyperacusis due to the stapedius paralysis. That is, a small sound can be heard very loudly. And deviation of the tongue on protrusion. Now, that is not affected because the tongue is not supplied by the facial nerve, but due to the proprioception of chorda tympani, the patient is unable to put the tongue is unable to identify the position of the tongue. So because one side is felt and the other side is not felt, due to the chorda tympani, there is a disparity of the movement or deviation of the tongue. Not in every patient. So Bell's palsy, other features are impaired blinking, sagging cheek, flattening of the nasolabial creases, slurred speech, diminished taste, hyperacusis, papillitis of the fungiform papilla. Again, one side of the tongue, the fungiform papilla is inflamed and there is a papillitis. So how do you manage the Bell's palsy? Medical and surgical. So medical is eye care. Beyond medical and surgical, the first thing is to care for the eye. And medical management is by giving high dose of steroids as well as antiviral medication. Prednisolone is the steroid which is commonly used. It's given at a dosage of 1 milligram per kilogram per day. And it is also supplemented with acyclovir or other newer forms of antiviral medication. Surgical treatment is basically decompression. That is removing the pressure along the inflamed part of the nerve. Other methods, if it is a permanent facial nerve paralysis occurs, then you can have neurography, or that is connecting another nerve. Graft neurography, cross-face nerve grafting, that is using the nerve on the opposite side and connecting another nerve, usually the sural nerve or any long nerve from, usually it is taken from the foot, and that nerve can be connected to the normal side and attached to the affected side. Again, nerve transposition. Temporalis lengthening. Temporalis lengthening is, you can use the temporalis muscle, you split it into, or rotate it downwards, elevate it from the bone and rotate it downwards, split it into small segments, and then you attach it to the areas which is needed, especially the eyelids, the upper lip, the lower lip. So those, over a period of time, when the patient tries to activate the temporalis by, say, just trying to move the muscle by clenching the face, the jaws, then when they clench, the movement of the lip and the eye occurs. So over a period of time, they train themselves to move their lip by actually clenching. Now, other methods are static suspension. Like I said, if there is a facial nerve paralysis, there is a total drooping of that side of the face. And sometimes we can use certain kind of materials to pull up the droop and make it into a normal, acceptable kind of position for the lip and the eye, especially for the lower and the upper lips, and suspend it in that position. Now, the best or the cutting edge method would be a neuromuscular transfer. That is, a nerve as well as muscle fibers from a different part of the body is harvested and it is attached to the muscles of the face or to the nerve on the other side. If it is a neuromuscular transfer, if it is used especially in cases where there is a palsy due to trauma, there is a cut of the nerve happening, or as it comes out of the foramen, after it comes out of the foramen, inside the parotid gland. So those are the occasions where neuromuscular transfer can be used. Thank you.